Good evening and welcome to the diabetes series of ICC Crack the Wellness Code. So without ado, we have a packed program today. This is the third of the diabetes series that we have for this year. The first two programs we had focused on lifestyle and diet related to diabetes. And the second one, we had some very, very captivating stories from health heroes. And this one, of course, we are focusing on tech solutions for preventives and therapeutics. There's a huge gap in terms of the care, which we'll hear today. And we're trying to see how technology is trying to fill that gap and how does technology is poised as far as diabetes-related challenges are concerned. So having said that, my pleasure to invite Hitesh Rastogi, who is been associated with CWC right from the beginning, since July 2018, and he's been a wellness champion all through. He has a deep tech background, worked with many tech companies, and he's currently building a health tech company, which of course at some point of time, I'm sure she's going to share whatever secret he can with you at this stage. So over to you, Hitesh.
Thanks, Som. Good evening, everyone. Happy Friday. My name is Hitesh, and I'll be the moderator. Along with me, we have two esteemed guests. We have Dr. Archana Bindra. Dr. Bindra is, I would call, a community physician. She has been practicing endocrinology over the last 16 years. Dr. Bindra is Director of Diabetes Care at Regional Medical Center at Washington Hospital. And Dr. Bindra did her fellowship in endocrinology at Cedars-Sinai Hospital. And along with her, we have Amit Shah, who is the Chief Operating Officer at Virta. And for those who don't know Virta, Virta Health is one of the leading healthcare companies, digital healthcare companies, pushing the envelope with respect to diabetes care. So with that, let me start with, we all know diabetes affects all of us, those who have the type 2 or type 1 diabetes 24/7. So that begs the question, shouldn't our care do the same? Supporting us from monitoring key vitals to helping us better control or even reverse diabetes. And more importantly, for situations where we take hold of early onset of complications so that diabetes is no more a silent killer. And what we're hoping with today's conversation is to get a perspective from a specialist like Dr. Bindra and also from our technology leader, Amit, as to, what are the gaps with respect to diabetes care and what role technology is playing and can play. So next time when you look for either yourself or for your friends and family who are, living with diabetes, we kind of drive the adoption of technology so that we can take care of, our health in a more proactive manner. So with that said, I'll pass on to Dr. Bindra to share her perspectives, as a practicing physician. Dr. Bindra.
Thank you, Hitesh, for that wonderful introduction. I will now share my slides. I've been in practice for many years, as Hitesh has mentioned, and there are definitely gaps in our care for diabetes. Diabetes is a problem that is worldwide, and of course, many people suffer from it. And with these times that we have, it is probably wise to know what we can do better about it to make it a better place for everyone. As you know, diabetes and medical care has evolved over time. There always has been traditional medicine where people have gone and seen their primary doctors. And a lot of times the discussions are primarily on a hemoglobin A1C that was done or a blood sugar test that was done. And if they brought their meters in, then their glucometer would have been occasionally been downloaded and maybe discussed. But that's pretty much what happens in our offices without the help of the latest technology. And a lot of times it's something like what's mentioned on the screen, that I have your lab results and some of it is high and low and they don't balance out, but here you go. And this is pretty much what we can do. So medicine definitely has evolved over time. With the advent of diabetes being detected much earlier, now that we check A1Cs at the age of 35, and even earlier if you have a lot of other comorbidities such as high blood pressure, high cholesterol, heart disease, and so forth, or if you have what we call gestational diabetes, if you have diabetes in pregnancy, again, it's checked at that time. Glucose levels have been detected at much earlier, lower levels than they used to be. When I started fellowship, the detection was at 140. Now it's at a fasting of 126. And we even talk about sugars more than 100 to be in what we call impaired fasting glucose, and A1Cs as low as 5.7, which we consider as pre-diabetes. The actual definition of diabetes would be an A1C of 6.5. So with all this advent, it's hard to practice just traditional medicine in order to achieve where we want to be. And as you know, people can be stuck in their ways. And I have practiced endocrinology throughout the entire spectrum. So I did my training at LA County, USC, which is a very typical county facility, very sick patients. After that was at Cedars-Sinai, which is in Beverly Hills, which had a very different affluent population. And then moved on to UCLA and was on faculty there, which is another affluent, semi-affluent area. And then came to the Bay Area and now have two practices. One is in Los Gatos, which is affluent, and one is at Regional Medical Center, which is not affluent. And you see a whole spectrum of how diabetes is managed and how the people in Los Gatos, some of them come with every possible machine that they know of or they want to be on, and their insurances pay for it. And whereas if you go to the other side, then they look exactly like this man here with the large phone and the large, clunky stuff that he brings in, and he doesn't want to change. We have a fair number of patients who don't want to change, who don't have iPhones, who don't necessarily want to get a new iPhone. They want nothing to do with technology at all. And so you're dealing with two varying types of populations, also from a different socioeconomic background, from a different cultural as well as education background, that don't necessarily understand why they would need to have these kinds of devices or apps or any kind of structure to help them with their sugars. They resort to using very, very old meters that can be downloaded and so forth. So we definitely have a very different kind of clientele all over, and we have to have different approaches to treat diabetes in those kind of clienteles. As you have noticed that some of these patients that I'm talking about in the poorer areas do not have a ride to offices. And that has always been a challenge. They always cancel their last minute visits. They usually don't bring their meter. They forget. Translation is usually a big problem because they speak either Vietnamese, Chinese, or Spanish, whatever it may be. It gets hard to communicate across and tell them exactly what you're trying to achieve and the importance of it. A lot of them don't realize that unless these sugars come down, you're not going to have a good outcome and you would have a lot of complications. So telemedicine, which I think has been around for a long, long time, only COVID made it actually more possible, where the insurance companies also realized that probably the entire health system will crumble if we don't start having telemedicine. And so a lot of our offices started doing telemedicine, either by talking on the phone or even through some kind of a platform such as Zoom or whatever the hospital or Kaiser or Stanford or whatever might offer for patients to be taught about diabetes through the computer. And so the convenience factor became very high, and you could reach out to people who were in the boonies, people who lived in places where there was no endocrinologist or no doctor for miles together. I have patients who are sitting happily in a mountain home somewhere and can be seen for their diabetes. And then of course there are some who live very, very far away and they could still be seen for diabetes. There was somebody who lost their home in the fire a year ago and could still be treated for diabetes from wherever they were. So the convenience factor has been a huge, huge bonus. And it has sort of transformed the way we look at medicine and its care. And of course, doctors are paid nowadays for this telemedicine, which never happened before. But telemedicine sometimes can be good and sometimes can be bad. Now you can see that this person is a dentist trying to tell this guy how to use a drill into his teeth through the computer. Now, I couldn't find something that was alluded to diabetes, but I think in diabetes, most of diabetes is a relationship of trust that has to be developed with your patient. And to develop a trust with a screen in the middle is kind of very, very difficult. How many of you would like to buy your car through a screen without even seeing it? Or how many of you would like to buy a fancy television that costs $5,000 just looking on a screen? You would like to go to the store and check it out. It's the same way, it's with patients. They feel that when you're being started on insulin or you're being told to do something new, that you want to develop trust with this person in order to feel comfortable that they are actually giving you the right advice, and you don't get those vibes when you're talking through a screen. It has definitely helped us to talk about nutrition aspects or to explain to them just diabetes in general. You could see how their house looks like. You could see what their surroundings are like. Of course, there's a convenience factor, as we mentioned, but what we don't get across is the trust, the hand-holding, the emotional component that doesn't exist with it. And I think that is something which is very hard to achieve through telemedicine, and it will always remain that way. So it definitely cannot solve all problems. And then I saw this slide and I thought it was kind of scary that the surgeon thinks that they can do surgery via Skype, and so that people should just go home and lie down in front of their computer. I recently actually had shoulder surgery at Stanford only a week ago, and I don't see my physician for the next 6 weeks. A lot of my visits are in between are on the computer. But I think me as a physician, I don't really mind that because I don't want to really go all the way to Stanford either. But as a layperson, I think it might be quite frightful to have stitches in your arm and nobody really seeing you. I'm not quite sure. So we have to realize how much telemedicine, how much we want to use it and how much we don't. So medicine has always been evolving. And right now, as far as the care of diabetes, we monitor it. There's so much of artificial intelligence. You could predict how blood sugars are going to rise with all the new sensors that we've been using. They actually can detect how the blood sugar will be rising over the next few hours, whether it's going to fall, whether you're going to have a low at night. So there are lots of things that it can tell you. So just a little bit of history about blood sugars and their sensors. The first time the sensor came about was, I think, around 2006. And it came with the help of insulin pumps. So insulin pumps are devices that give insulin to a person, primarily with type 1, but we use it with type 2 as well, through a tubing, and it gives you around-the-clock insulin delivery. And so one would naturally want to know what one's sugars are. And so Medtronic had the first insulin sensor, this first sensor device, but it was never a closed loop system, which means that the sensor never really talked to the pump and so forth. So it was like two separate entities. But that came out in 2006, and we would use them in our office, and we had to put it in a big black box, and so that it didn't have any kind of problems with connectivity and so forth. And it was kind of very Like it was like magic in those days, but it was around. And then slowly over the years, we've had different sensors come about from Dexcom and from Abbott, and they've become more and more easy to use. So we have 70% of our practices are now with these sensors. So patients just wear them for 2 weeks at a time, and then they can be downloaded in the office. And we kind of can know how they're doing at their sugars, make our changes. A lot of the times they can be transmitted across through us through some, some codes and stuff like that. And we can actually do it through telemedicine as well, which has been really nice, especially in COVID. So I'm not really going to go through all these different things. You can read it for yourself, but a lot of it goes through what we call the electronic medical records, whereby a lot of these things are tracked, prescriptions and medication refills can be sent, appointments and telehealth and patient portals are available. And then of course, there's always the people in the picture where you would have diabetes forums, social groups, but again, they can all meet on an app or on a portal someplace. So everything is evolving. And there's a smart everything available. So except, I don't know, we need to still find the smart doctor and the smart patient, but it seems like we have smart for everything else. We just talked about the continuous glucose monitors. We talked about there's a smart watch, there's blood pressure monitors, we have smart EKGs, you can do them in your house. There are smart drugs, which this is the gastroenterologists use them. You can see them as cameras as they go down your intestines, and all kinds of things. Smart everything, as I call it. But at the end of the day, physicians are designed to be, they were taught when it all evolved, they were taught to always take history taking and do a physical exam. And I think at the end of everything, I think that would be your mainstay. However much technology comes in your picture, technology is always secondary to what is being told by the patient. They say that 90% of the diagnosis lies in the history of what the patient is telling you. So if you just sit and listen to them, you will get your diagnosis. There are several companies, as Hitesh mentioned, who have come out with several technologies that help with downloading and sensors and detecting data and helping patients bring things down. But I just thought that I would give you the reality of how it is in the real world, seeing patients, a lot of diabetes patients every day. So I thank you for listening to me, and I'm happy to take any questions.
Thanks, Dr. Binder. I think this is very insightful. I think there are two interesting perspectives. The one perspective is about, the two spectrum of patients you talked about, the ones that are using the technology and the ones that are not situated to use much of technology. So I'm just curious, just for the audience, what has been your experience for the population that is more, ready to adopt technology? Are you seeing any changes in terms of their outcomes, in terms of the progression of disease, or just the quality of experience? If you could share, some of those experiences, hopefully that encourages the broader population to kind of start embracing it.
So yes, we definitely have seen a lot of change. There are patients who have come in with extremely high A1Cs, which are, we get them at 11, 13, 14, etc. And some of these patients, that correlates to sugars in the 500s or 400s or something like that. So those patients, once they have been started, we've had a few that once they have just been given the sensor and they saw how their sugars were, they automatically made their changes to their diet. And then sometimes it's just the diet that needs a change, and they started exercising and everything just changed dramatically. And they came down to a really good A1C. And so that is, of course, one very clear one end of the spectrum. We also had other patients who have utilized it and who have been able to bring down their medications dramatically, but who still continue to take meds, but are able to control it in a much better fashion. Unfortunately, these sensors are available through commercial insurances only. They are not available very much through, if you don't have a commercial insurance, and Medicare will cover it only if you are on insulin. You have to be on one dose of insulin to get it very easily through Medicare.
Perfect. Thank you so much, Dr. Binder. Let me, bring Amit Shah into the conversation. Little more about Amit's, background. Amit, he's been in some ways devoted his career all across multiple companies into the care of diabetes, as well as pushing some of the healthcare innovations. Amit leads the operations at Water Health, and prior to Water Health, he led direct primary care as a subsidiary of Davita, which in some ways is kind of a care that one would need, for the downstream from a diabetes. So with that said, Amit, would love to get your perspectives as you were at the forefront of, pushing the bar on technology-driven standard of care. So we'd love to get your, how you see the market moving, what are the practical challenges, and of course, talk more about how Water has been establishing a new paradigm, with a tech-led diabetes care.
Yeah, thanks, Hitesh, and thanks to everybody who put this panel together today. I'm really just grateful to be here, and so thank you all, and thanks for everyone who's attending. Dr. Bindra said, just had really pertinent and practical things to say. I would agree with a lot of what she said around equality and access driven by telemedicine, and how in some ways telemedicine is really working and improving, and in some ways it's really tough. I've got a couple of slides myself, so I'll share a couple of slides on what we what we do here at Virta, but most importantly, the technology that we use. And then again, happy to take some questions. I'm just going to spend a minute and just say who we are. As Hitesh said, I've been at Virta for kind of really spent a fair amount of time here. Been here for over 5 years now. We're a medical clinic, and so we do have physicians, but we deliver all of our care via technology. So we don't have any brick and mortar clinics, and we operate in all 50 states. So we've got patients across all 50 states, and we really focus on diabetes care. And so there are two pieces to what we do. The left-hand side is really personalized nutrition care. But the thing that I want to focus on is something that Dr. Bindra spoke a little bit about when she was talking about CGMs or when she was talking about sensors. Is we do have biomarkers. So we have and someone asked a question on checking blood sugar. I'll let Dr. Bindra answer that question from a care standpoint. But our doctors tell our patients at what frequency to test their biomarkers and put them into our system. And then by putting it into the system, we actually run what we call a technology-enabled continuous remote care platform. And so I'm going to spend a little bit of time today talking more about this continuous remote care platform as the technology behind how we actually deliver care. And so again, it's a pretty high-tech approach. We kind of coach people on what nutritional changes to make, as Dr. Bindra said. Nutrition, exercise, et cetera, are very important to changing care. We offer, we have health coaching. Everybody that is a Virta patient has a health coach and a physician. And so they're really able to personalize a lot of the nutritional protocol, a lot of the exercise regimen and all. But the way they personalize it that I think is really interesting is this biomarker logging. So every one of our patients gets a glucometer and a ketone meter, a connected weight scale, a connected blood pressure cuff. In addition, in our app, they're inputting a lot of subjective data. And then that leads to, on the back end in our EMR, our physician to provide proactive care, whether that's medication deprescription or further coordination across the system. So due to that technology, this is like, one of the things that, Dr. Bindra was saying, how difficult it is to establish trust across a screen. What we've found is that while what you lack in kind of the in-person model, which she's absolutely right. You can't hold someone's hand and see them individually. What you can do, though, is have really frequent interactions. And so our health coaches are often talking to our patients. And when I say talking, they're texting and messaging our patients in our app 2 to 4 times a day. And so that level of interaction allows kind of really proactive intervention with patients. And it's based on kind of this 24/7 data collection, right? Like we're getting blood glucose levels as they happen. We're getting ketone levels as they happen. We're getting weight levels as they happen. And so on the back end, we're able to take all of that data, and because it's all, to Dr. Bindra's point, in an EMR and structured, we're able to drive really personalized recommendations for all of our patients. Hey, Amit, you need to do X, which is very different than what Hitesh might need to do, and it's all kind of pulled together by our care team and our physicians. So it enables us to, this is kind of, it's an internal metric, so I won't spend too much time on it, but it shows, how things vary over time, and it's pretty real time. We're able to track things for patients over time, and then do both at the population level and at the individual level interventions. And on the back end, the interesting technology in our EMR is, most EMRs, as Dr. Bindra might concede, are like kind of nice. They're for care tracking, but they're heavily built around billing. And ours is really built very much around using this data to drive proactive outreach. And so, our physicians would get some version of a, algorithmic prioritization of their patients in their population with a summary and some things that they need to do. They would then, they would get a real-time clinical alert around something that is going on. And then it also suggests to them what intervention might make the most sense, given all the data that we have and the machine learning algorithm that would then, indicate what intervention might work. And so we kind of liken it to, like, instead of, really like the decision support system that allows us to drive really effective care based on real glucose data and real ketone data that the patient is giving us. We're also able to meet patients where they are in a really unique way, in that, if something's going on, we can, and you don't have to wait for the human to intervene. We could do some algorithmic problem solving. So you've got a headache, are you feeling sick? Give us some, and then it will take all of that structured data and it'll send it to our clinicians, so that our clinicians can reach out to you after you've already answered some questions. Sometimes, depending on what the symptoms are, we're even able to solve it without even humans coming into the picture, depending on what it is. So I won't spend too much time on this. I think part of what I'm just trying to show is that, in many ways, having that real-time connection and that ability to drive personalized care does result in some pretty interesting outcomes. And so the blue line are some of the outcomes we see at Virta. Pretty significant drop in A1C at 1 year and 2 years, very significant drops in body weight. And then, we're able to pull people off of their medications. And again, the technology piece is that we're able to personalize and individualize at scale. There's real-time continuous medical supervision, because again, there's all this data that's coming in. And then you have a lot of support from health coaches and other clinicians. So, and I'm going to share a quick video clip and then take some questions.
They told me I'd follow in my mother's footsteps. She died young from diabetes. That terrified me.
I was in constant pain, especially in my feet. I didn't know if I was going to be able to carry on doing my job with the pain that I was suffering from.
I was diagnosed at 27 with diabetes, and shortly after that, I was put on insulin. For me, that was scary.
They tell us all these things about what living with diabetes is all about.
What living with diabetes means.
But they're not true.
My job is to provide benefits and save the company money. I now have a life-changing solution for our employees and their families.
I'm not on insulin anymore, and it's a very big deal. Can't wait to see what's next.
I'm better at my job than I was 10 years ago. I don't deal with the constant pain, and I'm putting the young guys to shame.
So now I'm keeping up with my grandsons, and I'm eager to see what life has in store for me. I got teared up.
Thank you, Amit. This is really helpful. Just curious, how does this fit into, let's say, a practice like one of Dr. Bindra? From I think I'm sure some of the members would be curious to know how this whole thing comes together if I'm a patient.
Yeah.
What has been your experience?
Yeah, so as I said, we kind of run our own practice. We have our own medical professional corporation, and every patient that comes to Virta is part of our treatment. And that's because of the technology base, because it's real time, we're getting real time alerts, and we need physicians to then adjust medications and do things real time. We kind of have our own physicians, but we do coordinate with outside care. And so if one of Dr. Bindra's patients, for example, came to us and was working with us, Dr. Bindra would be getting consistent updates from the minute they start with us to at 15, 30, 60, 90 days, would be sending her updates around what we're doing with the patient, how it works. And again, that's one of the nice parts of having the technology platform is those updates we can quickly pull them together quickly and send them out automatically. And so that's how we are able to coordinate the care as effectively as possible. So
perfect. So let's start with some questions in the panel. I think these are some questions for Dr. Bindra. I think these are typical, questions. Dr. Bindra, the question says, how often should you check your sugar levels and when, and how much alcohol? And then I would, of course, love to get a perspective where technology could help.
Okay. So I guess checking sugar levels will all depend on how bad is the diabetes in general. But I think if you can have a sensor and have it on all the time, that would be the best. And if you cannot have the sensor for whatever reason, then I think checking after meals, couple of hours after meals would be very beneficial to know what the food is actually doing to your sugars. But really, it is actually more the better. So if you can do it many times a day, that's even better. It only tells you what's happening to your sugars throughout the day. As far as alcohol goes, I'm not a very pro-alcohol person, so the answer would be none. But alcohol has a lot of sugar, a lot of carbs. So I mean, if it can be avoided, then yes.
Gotcha. Thank you. And I think the next question we have is about some of the technology challenges. This is regarding the 14-day Libre continuous glucose monitor, and sometimes it doesn't align with the readings one would get with a blood glucose monitor like One Touch. What has been your experience? I'm sure you might have seen a lot of patients kind of sharing this kind of observation.
So the Freestyle Libre has the number 1 and the number 2. The number 2 is now more in real time as compared to the number 1. But when you're checking any of these sensors, they all go into the interstitial fluid as compared to what you're getting from your fingers is capillary blood. And so when food goes into your system, it always goes into the blood first and then into the fluid. So the fluid will always lag behind by about 10 minutes.
Gotcha.
That's why you see that discrepancy. Now, some people will say the discrepancy is very, very high. It also could be the placement of the sensor.
Gotcha. Let's get to another question. I think this ties to the role of weight reduction in diabetes and kind of the and what the body weight does with respect to sugar levels. So Dr. Bindra, if you could share your perspective, and then Amit, if you would love to get your perspective in terms of especially with water solution and what you see broadly, the role technology could play in kind of fixing this kind of an interplay between the weight and the blood glucose.
Wow, that's a broad question. But in general, about 7 to 10% of weight loss will definitely bring down sugars. I think there's a large role of insulin resistance that is played, which is hard to say how much a person would actually lose. But traditionally, you would lose, if you lose about 7 to 10% of your weight, your sugars will definitely start coming down and A1C will improve as well as blood pressure. There are various diets, which I don't think we want to go into today. There are a whole spectrum of them, and that would be a whole different discussion for another day.
Amit, your perspective?
Yeah, I mean, Dr. Binder's a doctor. Yeah, some body reduction of body weight's of course important. And what we saw in our clinical trial is we saw about like she said, about a 12% body weight, which is one of the reasons we see those types of A1C improvements. I think as it relates to technology, we do have the ability, again, because we're monitoring so many different biomarkers and now have done that for tens of thousands of patients, in a bunch of different settings, we're able to help people figure out what kind of what nutritional changes, what exercise changes, et cetera, they're making that's actually working for them. And so I guess the role in technology is to really help patients personalize, because of what Dr. Binder said. There's a lot of different stuff going on, and just having all that data. It actually relates somewhat similarly to the glucose monitoring question, which of course she answered so incredibly, because of the difference in the capillary blood versus the interstitial fluid. The other thing I'll add is that what we find is we sometimes have patients that have CGMs and that are also using a finger stick. And what in that case, what ends up being more important, as Dr. Binder very likely said, is the more data you get, the more finger sticks that you do, the more accurate you'll start to see these two readings are, because of the time difference ends up being not as manageable. So anyway, all that's to say that my answer on weight loss and all these is like, yes, the data is really important. And that's where technology can really help, because you can start to trend that data and understand what changes you're making to really drive long lasting change.
Well, perfect. As we say, if you can't measure, you can't, manage it. So, one of the recent development has been around using CGM with respect to tracking and managing metabolic health. There have been few companies like, Levels Health, January AI, and few others that's kind of looking at the more forefront of, let's call it, early onset of diabetes per se. What's your perspective on that? How you see, is it a hype, or is there a real value in using CGM for that purpose?
I would say the value there is very similar to the value I just shared, which is by having a CGM, you can see how different foods are impacting your blood glucose. And Dr. Binder, correct me if I'm wrong, but a lot of what endocrinologists are looking at today are time and range. And so she shared a lot of the different ranges that we're talking about. But let's say, you go out and you eat a bowl of ice cream, like that's gonna, you could see how that spikes your blood sugar, and how that might be different from if you, had a nice salad, right? Like that's not probably not likely to spike your blood sugar in the same way. So I think it's great. It's a great educational tool. That's what we see from Calibrate and Levels and some of these companies that you've talked about. They literally are just helping patients, or I'm not even sure they're patients, because I'm not sure they have doctors, and they're not actually establishing any care. So they're helping members, people understand the connection. And this is one of those things, I mean, Hitesh, you said it very clearly. This is one of the things that that's tough about our bodies, right? Like in general, we see a lot of patients that, to Dr. Binder's point, have blood sugars in the 400s, 500s, and you don't really know something's broken until pretty late in the process, right? Like, especially, we serve a large Medicaid population in Texas, for example. Like, they often, when people first come to us, a lot has gone wrong. It's like their blood sugar has been high for a very long time, and they're starting to feel some neuropathy, and like there's all this, there's some retinopathy, they can't see very well. And so that having a real-time device that starts to show you this, and starts to show you, it's a little bit like a speedometer. If you didn't have a speedometer in your car, I'm not sure you'd know you're speeding all the time. And like similarly, if you're not tracking this, if you're not looking at your blood glucose, you just don't know sometimes. So anyway, that's.
Thanks, Amit. Dr. Binder, what's your perspective as a physician?
So I think time and range is, of course, very important, because that's why checking it multiple times a day using a sensor would be very important as well. Different foods have different glycemic indexes, as what Amit was saying. Basically, eating a salad versus eating a nice ice cream would definitely cause a different surge in your blood sugars. I agree with that. Trying to get a CGM approved without having diabetes or being pre-diabetic would be think, an act of God in this day and age. It's very difficult. A lot of times people just pay for them. They are not that expensive. In fact, a lot of people, I just say it's like buying a ticket to India. Just think about it that way. You know, it comes to about $1,200 a year. And you could just go that direction and you would have a CGM for yourself.
Yeah, you know, let me just share my experience for those who want to try. At least my insurance covered it, even though I'm not a diabetic. And typically, if it's for education purposes, you pretty much need 2 census for about a 30-day period, and it costs about $70. Even if in case insurance, yeah, I mean the life liberate. Let's talk about 2 groups. One group is about the lifestyle interventions, you know, both for prevention and reversal. So the first question is, what percentage of doctors would recommend personalized lifestyle interventions before starting medications for newly diagnosed diabetes patients? What's your perspective, Dr. Binder, on that one?
So now, of course, you're asking somebody who's an endocrinologist. So I spend a lot of time on lifestyle intervention, but we also start medication sometimes at the same time, only because some of them come fairly late in the game. But otherwise, I think a lot of primary care, with the amount of time that they get to spend with the patient, and maybe with the knowledge base as well, they may not be spending that much time on lifestyle, and that's why they just start the meds.
Got you. And Amit, what has been your experience, you know, if you were to answer this question, you know, as you guys
Yeah, I mean, I think Dr. Bindra nailed it. I think that I prior to this job, I ran direct primary care clinics where we actually had a lot more time, and so we did spend more time on the lifestyle intervention. But to Dr. Bindra's exact point, it's because we had the time. You know, we structured it so that our average visits were longer, et cetera. And then I would say, I think that one of the hard parts, and this is where, again, I'll just relate it to technology, is that Dr. Bindra, not Dr. Bindra, a physician could recommend a lot of lifestyle change. And I think it's really hard to maintain lifestyle change over time. And I think that's one of the areas where technology is really helpful, where you can, you know, if you are testing your blood sugar, then regularly, if a health coach can contact you and they can see that data, as you know, as I shared that we do, I think that's a lot of where we're able to have the success that we have, because they're kind of real time helping patients, you know, between they see Dr. Bindra one day and then they see her probably like 90 to 120 days later. In that interim time period of 90 to 120 days, we can intervene a lot more proactively and really help them do what she's asked them to do. And that's a lot.
Gotcha. Moving on. So, you know, there's been a lot of talk about reversal of diabetes. Now the question to Dr. Binder is, you know, how many is everybody can reverse diabetes, or there's a typical situation that is more amenable for diabetes reversal? What has been your experience on that one?
So from what I have seen is that the lower the A1C, the greater the chance of reversal. Also because you've had it for a lesser amount of time, you have more what we call beta cells in your pancreas that secrete insulin that help you to function better. The longer you have diabetes, the more insulin resistance you are, the more obesity you have. It takes a longer time. It's not impossible, but it would be involving a lot of dietary and lifestyle change measures. And if people are willing to go about it, then yes, it will happen. I had a patient who actually is now a health hero here, but he came in with an A1C of 10.5 or 11 and is now down to, I think, less than 5. The man was, I started him on medications and insulin and everything. And I told him that if you change a lot of your lifestyle, and I kind of guided him into it. And I think he just took over and changed everything. The man lost more than 30 pounds, 30 to 40 pounds maybe, and completely reversed everything. So yes, it is possible, but one would have to make a lot of changes.
Got you. So basically, you know, earlier the better, and more you
That's why pre-diabetes has come in the picture. It's so that people catch things at an early stage.
Got it. And Amit, what has been your experience? You guys are pushing the bar with respect to diabetes reversal. What has been your experience in that front?
Yeah, I mean, this is an area that I could probably spend too much time on, but we and I, and I won't, but we actually are, some of our research papers are the ones that coined the term of diabetes reversal. We purposefully chose not remission and reversal instead. And so we, we believe that it is a broad solution. I agree with Dr. Bindra. It takes a good amount of change, but that is what we're all about. And so we believe that it's, we've had patients that start across the spectrum of A1Cs. We do C-peptide tests to Dr. Bindra's. C-peptide is a test that that looks for beta cell function, as Dr. Bindra mentioned. And so we do those tests to make sure that patients are able to reverse. But we have found our clinical trial results indicate success in about 65% of the patients we worked with, and even the 35% of the patients that did not reverse saw an average A1C reduction of about 1.5 points. And so, like, even if you're not completely reversing the disease, you're still able to get a lot better. Again, I quoted our average weight loss in that trial was about 12%, et cetera. And so it's a pretty, I think if people are interested in it, it's something that, as Dr. Bindra said, takes commitment, but is totally doable and is doable for a broad spectrum of the population. So, happy to talk about it, but I think it's a great solution. I've done it. I've reversed my pre-diabetes and I love it. So
yeah, perfect. Congratulations, Amit. Moving on to next question. And I think this is tied to, what families and friends can do. So the question is, how can I help my friends who have pre-diabetes when they visit me or come for dinner? Should I avoid all sugar? And I think the broader question is, again, the role of a family and where the technology could kind of help as a caregiver, as a support, because a lot of times when it's a lifestyle change, it's always helpful when the whole family or the friends, do it together.
I think, of course, eating together and getting together and being able to enjoy food is a big part of life. So if one can actually cook meals that are healthy, there are several websites. One of them is, which I commonly allude to, is Forks Over Knives. And I think it gives a lot of recipes to people who are, in search of something that they can even have a dessert. And I mean, the whole meal basically can be cooked from that. And it's a very nutritious meal. It's a whole food plant-based diet, which, so you don't really need to worry too much about the sugar content and things like that. I think that's one way to go. But other than that, you probably would have to cook basically cooking healthy food.
Yeah, so the idea is that, it's not like no sugar, it's just more healthy food.
Right. I mean, you can make everything, just make it healthy.
Gotcha. Amit, you have any perspective?
Yeah, I think, as Dr. Bindra said, I think food is a cultural thing. Especially, if you're South Asian, it's like a very cultural thing. And I'm Gujarati, so it's like especially cultural. Like, we only do things with sugar and food. So it's like, it's
that's stuff.
Yeah. But I guess I would say that I think the role of the family is to be supportive, and to understand the disease and understand the care plan that the patient is on. What we find with many of our patients, of which we've got thousands of kind of South Asian patients too, where there is a strong component of feeling like, to Dr. Bindra's point, like, you have to give something up to get something, and so you do have to make changes to your life. And I think as family and friends, you can be supportive of those changes, or you could be judgmental of those changes. And I think that oftentimes, what's different is looked at as with some judgment. And I would just encourage people to support others on their journey, especially if it's a journey of metabolic health. Like, there are a lot of things that you could do that are different that could work really well. And so I would encourage people to be as supportive as possible as people are trying to find their way on that. So.
Perfect. Thanks, Amit. One question. This is about more. How do we get sensors? If I as a patient want to get a sensor, how do I get it, Dr. Binder?
Oh, as a sensor, a sensor would need a prescription. So any kind of sensor, pretty much if your insurance allows it, you will get it. It's not that hard. If it doesn't, then of course you either pay for it, as we mentioned before, but that's pretty much, it does need a prescription.
And do we need any doctor can do it, or they have
Any
to be
doctor can do it.
any doctor can do it? Perfect. Dr. Binder, let's start with what's your kind of summary message, and then I'll follow with Amit and kind of go from there.
Well, I think the best is to eat healthy, stay healthy, exercise, and hopefully never enter the spectrum that we have to deal with it.
Technology can play a huge role in assisting patients and helping patients as they're trying to improve their life. And again, if there's, my parting thoughts are it's really possible. Reversal is possible. And so if it's something of interest to folks, they should, feel free to check us out. And you're welcome to email me or talk to me if you want.
Perfect. Thank you, Amit. Thank you, Dr. Binder. From my perspective, I think diabetes is a chronic condition that affects, health on a 24/7 basis. And as we laid out, technology fills a very key gap, and the gap is about monitoring almost real time, and then processing that data and providing insights that could be used back to either, facilitate lifestyle change for, reversing or, containing the progression of the disease. It can also play a big role in partnering with your clinician so that they can proactively take care of your care, whether they can catch a neuropathy, retinopathy early on before it kind of goes on. So I will say, as I wrap up this, I'll urge each one of us, either for themselves or for their friends and family, to really proactively look for technology-driven solutions, either directly or essentially work with your physicians, either primary care or endocrinologists, in kind of using and adopting technology. So with that said, thank you, everyone, and enjoy the rest of the evening.